arranged by the Yemeni Neurosurgical Society in collaboration with WFNS, Young Neurosurgery Forum, and Neurosurgery Coach, and Water Dandi Yemen Student Club, and Neurosurgical TV, and the Pakistani Society of Neurosurgeons. Today, we have two speakers. The third speaker, Dr. Victor, had a conference now, so he will not be able to join us later.
السماعة بس.
Okay. So, Dr. Mujahid. يلا انت بركة. يلا تمام.
I'm not hearing.
يلا دقيقة عندها بعد دقيقتين. So you can start introduce our speakers and then we start.
Dr. Ahmed, you start.
Okay, Dr. Mujahid, you can start to introduce our speaker, our first speaker.
Assalamu alaikum wa rahmatullahi wa jumu'ah barakah. For everybody, you are welcome. We will start today with Dr. Mahjabeen Maymoon, consultant neurosurgeon from Liaquat University of Medical and Health Science. First female consultant neurosurgeon in LUMHS and Hyderabad, with the title of this lecture, Anatomy of the Armpit for the Neurosurgeons. You are welcome, Dr. Mahjabeen, and everybody, you are welcome to this lecture. We can start.
Dr. Mahjabeen.
Yes, I'm here. Thank you so much for this introduction. And I'm honored to be on this platform to be presenting anatomy of the orbit. So can I share my screen?
Yes, Doctor, you can start.
Yes.
Is my screen visible?
Yes, perfect.
And audio is clear?
Yeah.
Okay, should I start?
Yes, it's time.
Yes, you can
It's
start.
already time, so you can start.
Okay. Assalamu alaikum, everybody. I'm Dr. Mahjabeen Maymoon, a consultant neurosurgeon working at the Department of Neurosurgery, Liaquat University Hospital, which is associated with LUMS, which is the institute, Liaquat University of Medical and Health Sciences, Hyderabad, Pakistan. Today, I'll be discussing something about the anatomy of the orbit for neurosurgeons. So it's a very vast topic, but we'll be focused on the anatomy of the orbit in respect to neurosurgery and its approaches. So to start with, the orbit is a cone-shaped structure with an approximate volume of 30 centimeter cube, and it is a very complex area. It's a very small area, but very complex area. And it comprises of several neural, muscular, vascular, ligamentous, and osseous structures that opens onto the face. So the base of the, if we see, I'm just showing the pointer. The base of the orbit is quadrangular in shape. You can see this. And the apex is triangular in shape, which is formed by the optic canal and the superior orbital fissure. We'll see. The orbit is made up of 7 different bones, and we'll see in the subsequent slides what bones make up the walls of the orbit. The contents of the orbit, as I already told, that it's a very complicated area, and there are a lot of structures fit in a very small space. We have the globe, several important cranial nerves, including the optic nerve and the extraocular muscles, and the nerves supplying the extraocular muscles, the ophthalmic artery and its branches, the ophthalmic veins. So it's a very pretty busy area, and we'll be discussing all of this today. The bony anatomy of the orbit, will start with the roof of the orbit. Basically, there are 4 walls. There is roof, lateral wall, medial wall, and the floor. And then there is an orbital rim and the apex. So we'll discuss one by one. The roof of the orbit is formed by the frontal bone, the orbital process of the frontal bone, and a small part of the posterior part of the roof is formed by the lesser wing of sphenoid. This is the roof of the orbit as seen from below. So this entire bone is the orbital plate of the frontal bone, and a small part is formed posteriorly by the lesser wing of the sphenoid. Also, we can see that there is supraorbital foramen, which is on the roof, and on the actually it is in the upper border of the the rim of the orbit, and it transmits the supraorbital nerve. We can also see the lacrimal fossa in the roof of the orbit. The floor is made up by two bones. One bone is the maxilla, and the other is the zygoma. So here we can see the floor of the orbit. Here, this entire bone is the maxilla, and the important aspect of the floor is this fissure, the inferior orbital fissure, which basically lies between the floor of the orbit and the lateral wall of the orbit. And we can also see this structure, the nasolacrimal canal, which transmits the nasolacrimal duct. Here, there is also a very faint groove, which we'll see in the subsequent slides, but we can appreciate a slight subtle groove, which is the infraorbital groove. And this groove allows the passage of the infraorbital nerve, which opens into the infraorbital foramen. Here we can see this is the infraorbital foramen in the face. Infraorbital nerve is basically the continuation of the maxillary division of the trigeminal nerve. The medial wall is one of the complex of all walls because a lot of bones actually contribute. 6 out of the 7 bones that form different walls of the orbit contribute to the medial wall. We can see this bone, the small green bone, which is the lacrimal bone, then this orange bone, which is the lamina papyracea. This is the orbital plate of the ethmoid bone. And this is a paper-thin bone, and it's an important landmark for entry into the orbit when we are doing endonasal surgeries. This is again the maxilla, and this small bluish bone is the palatine, the orbital plate of the palatine bone. Again, this is the sphenoid bone, and this lesser wing of sphenoid contains the optic foramen, and superiorly, a small part of the medial wall is formed by the frontal bone as well. The lateral wall is formed by the greater wing of the sphenoid and the zygoma, and again, to reinforce this concept, that there is a fissure lying between the lateral wall and the floor of the orbit, which is known as the inferior orbital fissure. We'll see that in a minute. The orbital rim is formed superiorly by the frontal bone, laterally by the frontal as well as the zygomatic bone, inferiorly by the zygoma and the maxilla, and medially by the maxilla and the frontal. So this is the basically orbital rim or the base of the orbit. This is another picture to further understand what we have went through so far. So we can see this superior orbital fissure, which lies between the lesser wing of the sphenoid and the greater wing of sphenoid, the optic canal, which is in the lesser wing of sphenoid, the inferior orbital fissure, which lies between the greater wing of sphenoid and the maxilla. And here we can see the part of the orbit which is called the apex of the orbit. The apex of the orbit is comprised of 2 foramina, the optic foramen and the superior orbital fissure. And the bone that divides these two is known as the optic strut. Optic strut is nothing but a bony landmark which arises from the anterior clavicular process and goes on to the sphenoid body. And this optic strut divides the optic canal from the superior orbital fissure. In the superior orbital fissure, we can see a small ridge as well here, which is important for the site of attachment of the annular tendon or the annulus of Zinn, which we'll see shortly. This is an again picture just for an overview. This is the roof formed by the frontal bone. This is the lateral wall, which is formed by the greater wing of sphenoid. And here we have zygoma. Here in the floor, we have maxilla. This important bone, again, lamina papyracea, which joins with the frontal bone with the, at the level of the frontoethmoidal suture, and these 2 foramina, here and here. These are the anterior and posterior ethmoidal foramina, which transmits the anterior and posterior ethmoidal nerves and vessels. Again, we can see the optic foramen, the suborb fissure, and the inferior orbital fissure. Now, this important structure, the superior orbital fissure, is a very busy area that involves several structures to enter into the orbit and leave the orbit. The superior orbital fissure is formed. This is basically the posterior view. We are looking at the superior orbital fissure from posterior. That is, we are basically right now in the middle cranial fossa, right? So this is the superior orbital fissure. It lies between the lesser wing of sphenoid and the greater wing of sphenoid. A small part is formed by the frontal bone as well, and medially a small part is formed by the body of the sphenoid as well. Again, the same anatomical landmark, the optic strut, which separates superior orbital fissure from the optic canal. This is the anterior clinoid process, and this is the area of the attachment of the annular tendon. The inferior orbital fissure, as we visited previously, lies between the maxilla and the greater wing of sphenoid. Here we have infraorbital groove, again very faint in this structure, but it allows for the passage of the intraorbital nerve. And the inferior orbital fissure opens posteriorly into the pterygopalatine fossa and inferiorly into the infratemporal fossa, as we can see in this picture. The orbital apex and the annulus of Zinn, basically this part, if I can. This part is comprised of a tendinous ring, which is called the annulus of Zinn. The annulus of Zinn basically is nothing but a common tendinous origin for the 4 recti muscle of the orbit. The annulus of Zinn has the optic foramen and the oculomotor foramen. This is the oculomotor foramen. The optic foramen allows for the transmit of ophthalmic artery and the optic nerve. Then this oculomotor foramen allows for the passage of other cranial nerves, as we will see, including the oculomotor nerve, nasociliary nerve, and the other nerve, which is the abducens nerve. We'll see shortly in the subsequent slides. Again, this is the annulus of Zinn, the optic foramen, and the oculomotor foramen. We'll see all these muscles and the nerves in a minute. Again, a simplified diagram. So this is the annulus of Zinn. Here we have the superior rectus, medial rectus, inferior rectus, and lateral rectus. This is the levator palpebrae superioris, but it lies outside the annulus of Zinn. This is a more detailed diagram. We are seeing at this structure, at this level, and this entire tendinous ring is the annulus of Zinn. This is the superior rectus, medial rectus, inferior rectus, and lateral rectus. This is the optic nerve, the ophthalmic artery, and this structure is the superior division of the oculomotor nerve. This is the inferior division of the oculomotor nerve. This nerve is the nasociliary nerve, which is a branch of the ophthalmic division of the trigeminal nerve. And this nerve, obviously, which is going to the lateral rectus, is the abducens nerve. Outside of the annulus of Zinn, now this is a very important aspect to understand, and it's also important for the exam point of view, that the structures that lie outside of the annulus of Zinn are these two nerves. This nerve is the frontal branch of the ophthalmic division of the trigeminal nerve, and this is the lacrimal nerve, which is also a branch of the ophthalmic nerve. Another structure that lies outside of annulus of Zinn is the superior ophthalmic vein and the inferior ophthalmic vein. And this small nerve over here, this is the trochlear nerve that goes on to the superior oblique muscle. This nerve also lies outside of the annulus of Zinn. This is a very important concept to understand. Now, once we've understood the annulus of Zinn, we'll go to the stepwise dissection of neural structures in the orbit. This is the floor of the anterior fossa. And after looking at this, this is the frontal bone. This entire is the frontal bone. Once we remove the frontal bone, we can see the frontal sinus, the ethmoidal sinuses, the sphenoid sinus, and this structure, which is the periorbita. This entire is the periorbita. Once we open the periorbita, this is the reflected, these are the reflected ends of the periorbita. We can see the globe. The three important nerves that we can see, obviously optic nerve is on its way. I'm excluding optic nerve. I'm just talking about the nerves that are entering through the superior orbital fissure. The three nerves that we see are the frontal nerve, which is a branch of the ophthalmic division, which divides into the supratrochlear nerve and supraorbital nerve, which is faint here. Another nerve is the lacrimal nerve that goes laterally to the lacrimal gland. And this nerve, not to be confused with the nasociliary nerve, because we have the concept that the ophthalmic nerve enters the superior orbital fissure and divides into these three divisions. No, the nasociliary nerve, as we saw previously, passes through the annulus of Zinn. So what is this nerve? This nerve is the trochlear nerve that goes on medially to the superior oblique muscle to supply it. We see in the subsequent dissections. Again, the same picture, but with labelings. The frontal nerve, fourth trochlear nerve, and the lacrimal nerve. Now this is a clearer picture. Again, the frontal nerve, right? It's going medially, dividing medially into the supratrochlear nerve, and this is the supraorbital nerve. This is the superior oblique muscle. This is the pulley, that is trochlea. We know with which it crosses and attaches to the globe. And this nerve is the trochlear nerve. This is a lacrimal nerve going laterally. The important landmark here is that once we go deeper, there are few structures that cross the optic nerve. This is the optic nerve, and there are few structures that cross from laterally to medially above the optic nerve. One of the important structures is the superior ophthalmic vein, the other is the ophthalmic artery, and the third is this important nerve, the nasociliary nerve. And these three structures crosses the orbit from lateral to medial above the optic nerve. If we go further deep and we open the annulus of Zinn between the superior oblique muscle and the levator palpebrae superioris, we can have this medial corridor, but we have to save this nerve, which is the trochlear nerve. Again, this is the trochlear nerve that we can see. And if we divide the annulus of Zinn between the lateral rectus and the levator palpebrae superioris, we can have this lateral corridor. This is the entire lateral corridor in which we can see the ophthalmic, superior ophthalmic vein, the optic nerve, the ophthalmic artery. But the fact is that we have to retract the superior ophthalmic vein laterally towards the lateral rectus, because if we are going to retract it medially, it will be blocking the access to the lateral part of our field. So this is the same picture zoomed in, that we have opened it between this muscle, that's the levator palpebrae superioris, and lateral rectus. Once we have divided the annulus at this level, we can see clearly the structures that we should be able to know. This nerve, this entire nerve, is the oculomotor nerve. It divides into the superior division and the inferior division. The superior division goes on to supply the superior rectus and the levator palpebrae superioris. The inferior division goes on to supply the inferior rectus, inferior oblique, and medial recti muscles. Also, we can see this nerve, the abducens nerve, which is going to supply the lateral rectus muscle. This is the lateral rectus. Again, this is the ophthalmic artery, the deeper part in which we can see the optic nerve. And this nerve that is passing through the annulus of Zinn, along with the optic nerve and ophthalmic artery, is the nasociliary nerve. The nasociliary nerve is, again, as we knew, that it's a branch of the ophthalmic division of the trigeminal nerve. Okay, this structure is the ciliary ganglion. These are the motor branches from the inferior division of the oculomotor nerve going on to the ciliary ganglion. And this is a sensory branch which goes on to the nasociliary nerve, and it is going also to the ciliary ganglion. Another important structure is this nerve which is going outside of the annulus of Zinn all the way up to supply the superior oblique. This is the trochlear nerve, and this is the superior ophthalmic. Same dissections with labeling. I think it's clear, but again, we'll have a brief overview. This is the frontal nerve, supratrochlear, supraorbital nerves, fourth nerve, cranial nerve, that is trochlear nerve. This is the lacrimal nerve going on to the lacrimal gland. This is the nasociliary nerve lying deep within the annulus. And then we have the lateral rectus, the superior rectus muscle, the levator muscle, and the superior oblique muscle. If we open the tendon between and we reflect the superior rectus in the levator palpebrae superioris and the lateral rectus, we can see further deep structures. Again, the structures passing from lateral to medial, that's the superior ophthalmic vein, the nasociliary nerve, the ophthalmic artery, and further structures we can see after reflecting these structures laterally. Again, here we have opened the dura of the middle fossa as well to see how these cranial nerves enter into the superior orbital fissure. So we can see the cranial nerve 4, cranial nerve 3, and cranial nerve 6 entering to the superior orbital fissure. We can also see the Gazarian ganglion and the 3 trigeminal divisions of V1, V2, and V3. Again, a zoom in view. Here we can see the divisions of the oculomotor nerve. This is the superior division, and this is the inferior division. The inferior division is important that it gives the branches to the ciliary ganglion. And the superior division, as we saw previously, it supplies the superior rectus and the levator palpebrae superioris. The inferior division give rise to the inferior oblique muscle, innervation to the inferior oblique muscle, innervation to the medial rectus, and innervation to the inferior rectus. A brief overview of the cavernous sinus. The cavernous sinus is the part, and the lateral part of the cavernous sinus is the area from where all these nerves pass to enter into the superior orbital fissure and then subsequently into the orbit. So this is the anterior clinoid process. This is the third nerve. This is the fourth nerve, trochlear nerve. This is the ophthalmic division of the trigeminal nerve, and this nerve is the abducens nerve. All of these nerves, they pass through the superior orbital fissure to enter the orbit, and this is the ophthalmic vein. This is the second division, which goes on to the foramen rotundum, and this is the V3 that goes on to the foramen ovale. If we go further, if we go and have a closer look, we can see that sixth nerve, this is the sixth nerve. It passes all the way from the Dorillos canal and it goes medially to the V1, that is ophthalmic nerve, and then enter into the superior orbital fissure. The same nerves, third nerve, fourth nerve, sixth nerve we already saw, V1 and the ophthalmic artery all the way passing through, not the ophthalmic artery, sorry, but branches of the supracrinoid ICA passing through the superior orbital fissure. So going on to the ophthalmic artery, it provides the major blood supply to the orbit and the optic nerve, and it arises from the supraclinoid artery. It's important not just that it supplies the or optic nerve, but it also supplies the other structures in the orbit, and it provides an important anastomosis between the internal cerebral artery circulation and the external carotid artery circulation. So this is the ophthalmic artery. It goes on to give this branch, which is the ciliary artery, this branch, which is the central retinal artery, and then it divides into the terminal branches, that is the anterior and the posterior ethmoidal arteries, and they pass to the anterior and posterior ethmoidal foramina, as we saw previously in the bony dissection. Further closer views of the ophthalmic artery. This is the ophthalmic artery. This is the branch, which is the central retinal artery, which enters the optic nerve. This is the ciliary artery. And here we can see again the ophthalmic artery going from lateral to medial here, right? And it is dividing into the anterior and the posterior ethmoidal arteries. Again, the central retinal artery, the ciliary artery, and here along with the ophthalmic artery, we can see this nerve, that is the nasociliary nerve. The superior ophthalmic vein, which also crosses from lateral to medial, has been divided. This is the important view in which we can see the central retinal artery here. And it's very important during surgery that we have to take care of this vessel. It's a very small vessel, but once it is involved or it is coagulated or bipolarized, it can result in blindness. So you have to be very careful about it. The venous drainage of the orbit is via two major vessels, major veins. That's the superior ophthalmic vein and the inferior ophthalmic vein. Both of them mostly join, and they form a single stem that drains into the cavernous sinus, but sometimes they can drain separately as well. If we see the front view of the orbit, we can see all of these structures that we have went through. This is the levator palpebrae superioris. This is superior rectus. This is the trochlea, that is the pulley. So obviously this will be the superior oblique muscle. This is the medial rectus, inferior rectus, the inferior oblique muscle, the lateral rectus muscle. And this nerve, which is going towards the trochlea, obviously will be the supratrochlear nerve. And obviously we know that this is the sclera, this is the cornea, and all of this stuff. The brief overview of the orbital lesions. In order to understand the orbital lesions, we should understand different compartments of the orbit. So there are four compartments. There is this intraconal space that lies within the annulus of Zinn, the extraconal space that lies outside of the annulus of Zinn, and then we have the ocular lesions like globe lesions, and then we have the optic nerve sheath lesions. So we already saw, it's just a summary of what is present within the conus, within the annulus of Zinn. These all cranial nerves like optic nerve, oculomotor nerve, nasociliary nerve, abducens nerve, they are within the intraconal compartment, and the extraconal compartment, that is the nerves that go outside of the annulus of Zinn. They are the lacrimal and frontal branches of the ophthalmic nerves and the trochlear nerve. So the lesions can be intraconal, and the intraconal lesions can be either placed situated medially, centrally, or can be either placed laterally, centrally, or medially. As far as extraconal lesions are concerned, they can be present between the muscle and the periorbita. They can be in the orbital wall, or they can be outside the orbital wall. For example, this is an intraconal lesion, an optic glioma that is compressing the globe and it is causing proptosis. So we should know that in intraconal lesions, the proptosis is central proptosis, whereas in the extraconal lesion, like this is a sphenoorbital meningioma, which is compressing the globe, and it is also causing proptosis, but this proptosis is abaxial proptosis. These are the different orbital lesions, and we are not going into the detail of these lesions, just an overview which I gave. The optic nerve is important in segments that we should know a few segments of the optic nerve. There are 4 segments. The smallest segment is the intraocular segment, which is of just 1 mm. The other segment, second segment, is the intraorbital segment, which is the longest segment. It is around 25 to 30 mm in length. The intracanalicular segment lies within the optic canal. It's 9 to 10 mm, and then intracranial segment, which lies within the cranial cavity, it is around 10 to 15 mm. A few words about the orbital approaches. The approaches of the orbit basically can be understood in a way that there are 360-degree approach to the orbit. Like we can have medial orbitotomies, superior lateral orbitotomies, and the inferior orbitotomies. So as far as superior lateral orbitotomies are concerned, if the lesion is very extensive and large, we can go through a pterional craniotomy, we can go through FTOZ approach. If the lesion is very small and laterally located, we can just go through a small lateral orbitotomy. And if the lesion is very small and located just in the roof, we can go through a keyhole approach, supraorbital keyhole orbitotomy. If the lesion is in the floor, we can add additional zygomatic osteotomies that can enable us to reach the lesions of the floor of the orbit. We can go through maxilla to reach the floor of the orbit as well. That's one of the pathways. And for the medial lesions, we have obviously the revolutionary endoscopic endonasal approaches through which we can break down the lamina papyracea and we can enter into the medial orbit. So again, the brief overview of the superior and lateral approaches. If the lesion is large, we can go for larger craniotomies and orbitotomies, but if the lesion is small, we can go through a small lateral orbitotomy. And this is the exposure. This is quite a good exposure that a small lateral orbitotomy can give us. It's a lacrimal gland. This is the lateral rectus, and if we retract the lateral rectus, we can have the view of the entire internal structure. This is again an example of a small lateral orbitotomy that can be done. And again, this view is seen when we do a small lateral orbitotomy. We retracted the lateral rectus above. We can see the optic nerve, the ophthalmic artery, the small nerves along with it. And this is also a very for small lesions, it's also a very good corridor. But if the lesion is very large and extending superiorly as well as the lateral wall of the orbit, we can go through the frontotemporal zygomatic osteotomies in 1 piece, in 2 piece, or in 3 piece. To the floor of the orbit, we can go via the maxilla, and this is the maxillary antrum. The roof of the maxilla also forms the floor of the orbit, so we can go through the roof of the maxilla as well to reach the floor of the orbit and its structures. The medial wall approaches, as we already discussed, this is the lamina papyracea. These are the ethmoidal air cells. If we enter through the endonasal surgery, we can enter the ethmoidal air cells, we can break the lamina papyracea, and we can enter into the medial wall of the orbit. So this is the lamina papyracea. This entire wall is the lamina papyracea, which is nothing but the orbital plate of the ethmoid bone. And if we break down this, we have a very good exposure of the medial wall of the orbit and periorbita. Further, if we open the periorbita, we have this medial rectus, the inferior rectus, and the superior rectus, and the superior oblique muscles, and we can see globe, the ophthalmic artery, and all these structures that can be seen. Thank you so much.
Thank you very much, Dr. Mahjabeen. Dr. Mujahid. Please unmute, Dr. Mujahid.
Thank you, Dr. Mahjabeen, for this nice presentation. And thank you, Dr. Ahmed, for your good preparation. And we can start now for the second lecture with Dr. Aibe. Dr. Aibe Cherian, the director of this. Iberian Director of Institute of Neuroscience of Krishna Institute of Medical Sciences, Parad MH, India, with the title of the lecture of Microsurgical Anatomy and Approaches to the Anterior Skull Base. We can start, Dr. Ibe. Is here?
Thank you very much, Mujahid. Can you hear me? Can you hear me?
Yeah, I'm hearing you. You can start.
Yeah.
With the great
Thank
thanks.
you very much. An excellent lecture. Previous lecture was very good. So I will start. And since I'm traveling, it has been pretty difficult for me to do this presentation. But Ahmed has very kindly agreed for screen sharing. He's screen sharing and I'll talk from my phone. So these are the beauties of technology. So we can start the first video, Ahmed.
Start.
Yeah, so these are some of the things that I described. They are about axial and sagittal unlocking. Could you go back? Yeah, this is sagittal unlocking, where to reach the skull base, one has to understand it's not a skull base, it's a brain base. So the brain, unfortunately, has many curves. So you have to do this. This is called the sagittal unlocking. And how you do this is drilling the entire sphenoid ridge there, what Ahmed is showing, and then even taking out the clinoid process. That's called the sagittal unlocking. That gives you a direct pathway into the skull base and the cisterns. And the next is axial unlocking. You can advance it. Yeah, this is axial unlocking. What happens here is you're taking the temporal lobe away from the cavernous sinus. And when you do that, there is a bloodless way of doing that. We have published it as the orbitomeningeal band being the route for the bloodless translocation of the temporal lobe away from the cavernous sinus. And when you do that, what you do is you get a beautiful pathway to the interpetuncular cisterns and the posterior cisterns. So also you can do an intradural unlocking. That is the Sylvian Fisher dissection. So when you have axial unlocking, sagittal unlocking, and intradural unlocking, you have all three unlockings to the skull base. So we're going to show you some of the videos that we did. One is a craniotomy here, and you can see the frontal lobe and the temporal lobe. The frontal lobe below and the temporal lobe down there. This is all done in Krishna. We have an Esculap Academy with soft embalming and injected cadavers. So right now we are going to do the sagittal unlocking, that's drilling of the entire sphenoid ridge and exposure of the orbitomeningeal band. So the orbitomeningeal band is between the frontal lobe, temporal lobe, and the orbit. So you're slowly incising the orbitomeningeal band. That's the orbitomeningeal artery. Yeah, so that's where the orbitomeningeal artery comes in. So what you're doing is once you cut that, you are going to retract the temporal lobe away. That's what I'm doing right now. You're going to retract the temporal lobe away from the cavernous sinus. Now the cavernous sinus roof is being, under the anterior clinoid process, the cavernous sinus roof is being slowly dissected away. And although I don't do anterior clinoidectomy like this for paraclinoid aneurysms or such, but most of the other times you have such beautiful exposure of the clinoid that you may be, with a clinoid punch, you can easily take out the. And what you're seeing right now is the carotid. And the beauty is that you can see the proximal dural ring and the distal dural ring. That's a paraclinoid. And then now you're skeletonizing the optic nerve. Medial to that exposure, you're skeletonizing the optic nerve. So that is further skeletonizing the optic nerve. So you have the paraclinoid carotid, you have the cavernous sinus, and the lateral cavernous sinus, you are peeling it away. So you have the optic nerve now, you have the paraclinoid carotid, and now you're exposing the cavernous, the entire cavernous sinus. You are slowly going ahead and taking the temporal lobe away. So now you can see the third, fourth, the second, third, fourth, V1, V2, and V3. So this is the exposure that you can get. And you go ahead with the fourth and V1 triangle. So you will see the meningohypophyseal trunk going backwards. And between the fourth and V1, you will see the sixth nerve also below the petroclinoid segment, that petroclinoid ligament. The fourth, the beauty of this is you can see both the ligaments. One is the posterior petroclinoid ligament, which runs above, and then you have the petrosphenoid ligament, which forms that is the sixth nerve in yellow, and the petrosphenoid ligament, which forms the roof of the Doralo canals. So both you can cut and you can free the sixth nerve completely. And this is something that we do during surgery. So once you control the bleeding there, you can, with our homemade mixture, anybody wants to know, then we can tell you about the homemade mixture also. So this is the opening up the Parkinson's triangle. So you see, endonasal route to the cavernous sinus may be a little bit of a problem because you're seeing everything from end on. And here you're seeing everything from side on. And you can see here the sixth nerve, third nerve, fourth nerve. And we have gone into the posterior fossa. And you can see the basilar there. You can see the SCA there, third, fourth. And you can see the sixth nerve there. You can see the V1, V2, V3 there, the Gasserian ganglion there. So we're going to use this anatomy for two cases. That's what I'm going to show you also. And we're going to expose the second nerve, the carotid now, the opticocarotid window, nicely open there. Then you're going extra, intradural, extradural combinations of exposures. That's a posterior clinoid process between the carotid and the third nerve. And once that is taken out, then you have excellent exposure to the proximal and distal basilar. So proximal, that's the PCP. You can take off the dura of the PCP and then drill the PCP. So our paper on drilling the PCP at least 7 years back has been one of the papers which describe how the PCP is drilled in detail. I think it's an Asian journal. So once the PCP is exposed, you can see the basilar very clearly. Now it's very important to make that incision on the PCP, dural incision on the PCP. and then inject the glue there. I mean, in a cadaver, it doesn't matter, but when you are doing a case, you can see videos of this in my YouTube channel of how to do it during a case. So you can take off the PCP there, drill it, and then reduce the dura over that drilled PCP. And then you will get excellent exposure of the posterior fossa. That's a basilar artery behind the PCP. So this is a combination of Dolenz, Kawase, everything together. We described it almost 8-9 years back, and we've been teaching this from that time. 2014 onwards, we've been teaching this. We classified the carotid also and published this. Our classification of the carotid, I would ask probably Nargisa to put up that article in the chat group so that people know about that that classification, which is really easy. Now we develop, along with the opticocarotid triangle, we develop each of the other triangle like Parkinson's and the triangle below the Parkinson's also, so that you can get an excellent exposure to the posterior fossa through the transcavernous route. It's a beautiful highway. So you can see the paraclinoid ICA, optic nerve, and the pathway. This is the overview. And once you open the cisterns, then the brain will be quite lax. And I believe Yohei Miura has also started of late doing this same approach, which we described in a minimally invasive way, and he calls it Mi-Plata. Now I'm going off to the Kawase side of it. That is dissection of GSPN behind the V3, and then exposing the Kawase triangle. So earlier we used to drill the V3 all the way down, skeletonize it, and move the entire V3 anteriorly. That is in case of expanded Kawase, but this is beyond the scope of this talk. So I'm doing a sub V3 drilling below the V3, and I'm going beneath the V3 and drilling the true Peters apex also, but taking care of where the carotid comes. And thank you, Nargisa. So that paper actually shows the unlockings of the brain along with the. So here I'm exposing the 7th nerve anteriorly, and I can drill all the way behind also. That means up to the superior semicircular canal, that is called post-meatal drilling. This is to maximize the Kawase triangle. This way, we can go ahead and do many tumors. Right now, I'll show you a cystic petroclival where we did this. This is the 7th nerve. So for a petroclival tumor, you need to expose only between the 5th and the 7th. Very, very focused approach. So now you have an overview from 2nd nerve to 7th nerve. Transcavernous approach, and then you have also the 7th and 8th nerve. So all the triangles are shown here. I hope the participants can come to Krishna sometime, like Nargisa had spent some time with us, Ahmed had spent some time with us as well, long time back. So you can come to our place, and then we have a Esculap Academy lab with soft injected cadavers, and dissection is something that we love. The first thing to, if you have to do neurosurgery, you have to, first thing is lab. Remember that. Now we are starting something called ultra micro neurosurgery. For 4 years, we've been talking about ultra micro neurosurgery, where you operate at zooms of 40 to 50 or up to even 70 using exoscopes. I believe that's the future. So I'm developing each of these windows now. Each of these windows are being developed, and the dural sheath is being slowly reflected from the 5th nerve. So you have a complete transcavernous highway all the way from 2nd nerve to 7th nerve. Each cranial nerve is skeletonized. So this is the way to go ahead with the sphenopetroclival tumors. And we will show you some cases as well using this anatomy. Can you show the, okay, so now this is an overview of the entire anatomy. So you can see the ICA, and in fact, through the third, between the 3rd and the 4th and the B1, you could even see the basilar and all the other vessels, as well as we showed you just now. So this is, in short, the anterolateral triangle. So it's another video that we are going to show you. Ahmed, can you show me the second video, please? Yeah, so this is a minimally invasive, minimally access petroclival lesion. You can see one thing. Ahmed, can you pause this here, please? You can see the basilar artery. On the first cut, you can see the basilar artery very, very close to this lesion. You know, cystic lesions, you can see the lesion and that dot there. And if you magnify that dot, there is a small vessel next to the basilar, very adherent to this cyst. And if you pull out this cyst, that can result in the tear of that artery from the basilar. So we went ahead and did something called total internal decompression. Here we went ahead and approached it just like we did in the last dissection. And it is between the 7th and the 5th nerves. So true petroclival junction. You can advance the video, please. You can advance it a little bit more faster. So same thing, meningoorbital band. You can advance this, Ahmed. Yeah, advance it a little bit more. Yes, thank you. So I am drilling the petrous apex there. Drilling the petrous apex after cutting the meningoorbital band. Now I think after you've seen that other video, you have a clear idea of how I'm doing it. Now I'm using the tailored petrous apex apicectomy by using a bone knife. I don't have to go to the carotid here. because this lesion is cystic, and once I open the cyst, I'll get enough and more space. The first thing you learn is to expose maximally, and then once you have enough experience, you learn to expose minimally. That's the paradox of neurosurgery. So there you are exposing all the way till the IAM. Then you are cutting the superior petrosal sinus. You are bipolar, and you can cut the superior petrosal sinus. You must understand that it runs over the fifth nerve. So you must be careful not to cut the fifth nerve after bipolaring it. So you must, it runs right above the fifth nerve, the superior petrosal sinus. So sometimes putting, without realizing this, if you put clips and all, you can damage the fifth nerve. So I'm opening the Meckel's cave now, finding the tumor there as well. Just like I did in the cadaver dissection, I'm doing that. So that's the Meckel's cave with the entire fifth nerve there. And then I'm going on to open the, once I open the Meckel's cave enough, then I'm going to open the tent. Here already I have cut the lateral aspect of the tent, going to the medial aspect of the tent, completely opening this. So it's very, very important to do that opening in a Kawase, because if you don't do that, see, that's the medial most margin of the tent where the brainstem is. So you will see the fourth nerve also there. Now you decompress. That's the seventh nerve posteriorly. Posteriorly, this is the seventh nerve. That's the seventh nerve. That's the seventh nerve. And I'm between the fifth and the seventh nerve. My exposure is completely between the fifth and the seventh nerve. So I cut the solid portion of the tumor, get into the cyst. Then I use CUSA to do something called total internal decompression, which means I'm taking the tumor from inside out. So we have started doing it in vestibular schwannomas also. So the whole point here would be not to pull out the capsule. And therefore, when you don't pull out the capsule, what the good thing about that would be the vasa nervorum of the eighth nerve can be saved. So we are between the fifth and the seventh nerve. You can see the fifth and the seventh nerve between, and I'm operating between that. True petroclival angle, and I'm using the CUSA to take out all the solid parts of the tumor. And once I know that I'm very close to the basilar, the CUSA, this CUSA can injure the basilar. You see, this is the barracuda tip, and can injure the basilar. Very, very careful. You must be very careful with that. And once then I put in an endoscope, and through the endoscope, I can see the basilar there. You see the right picture, you can see the basilar there. That's a basilar. That's a tumor, and next to that is a basilar. So once you can see now the basilar now in the exoscope, and that small vessel. You can see the small vessel. That's a vessel. That's a vessel. So all the capsule, everything is slowly taken out. That's the next video can be shown. That's a cavernous sinus tumor. Ahmed, you can start sharing the next video. Yeah, so this is truly a cavernous sinus tumor, medial and lateral to the carotid. T2-weighted hypointense, very, very dense tumor, and very enhancing tumor. So in this case, we are going to do the same thing, that is cutting the meningoorbital band. On your right side is a frontal lobe, left side is the temporal lobe, and we're going to cut that and use ultra micro neurosurgery. That is very high zoom to go in between these nerves and take the tumor out. So you're cutting the orbitomeningeal band and then going medial to the temporal lobe. Temporal lobe is being lateralized, just like in the cadaver dissection. When you do that, you are already seeing the tumor lateral to the cavernous sinus, and you're removing the tumor lateral to the cavernous sinus. It's stuck to the temporal lobe. All that tumor is being removed. So you keep on removing all that tumor, and then you can see medial to that, you can see the cranial nerves, everything off the cranial nerves you remove. Then you have to go between the cranial nerves. Those are the cranial nerves. You have the fourth nerve, you have the fifth, V1, V2, all that you have there. It's under very high zoom. So you keep on dissecting the temporal lobe away, and that's your clinoid process. That big thing is your clinoid process. You have third nerve there. And you cut the APCL, that is the anterior petroclinoid ligament. And then you drill the clinoid process away. So unlike the last time where you showed, where I showed you taking the clinoid out, like with a punch, for a tumor like this, I would prefer to drill it with a 0.75 millimeter tip. I would do that also for paraclinoid aneurysms. Even when they have ruptured, I take out the clinoid this way, extradurally. I've been doing that for so many years. We go ahead and take out the optic nerve roof also. Under very high zoom, very high zoom. We divide the clinoid into sectors and then drill each sectors out under extremely high zoom. This is zoom of around 40. So drill out all this under a lot of water as well. So you can see the tumor in the clinoidal triangle peeping out. Completely free the optic nerve, and then that's a clinoidal triangle. Optic nerve medially, third nerve laterally. You have the fourth nerve, thickened fourth nerve. You have V1, and then you go between the fourth nerve and the V1. That's a Parkinson's triangle. You must be careful about the sixth nerve and the inferolateral trunk. So inferolateral trunk is coming out from the carotid and just going above the sixth nerve. So you must be careful about that. So I'm opening the windows. People tell me that you can have cranial nerve palsy unless you bipolar the cranial, bipolar here, very, very difficult to have lasting cranial nerve palsy. And don't believe in gamma knives. I really don't. That's because maybe gamma knife is a fantastic option, but we have a better option. We are surgeons, so we have a better option. And our patients sometimes cannot pay for gamma knife, or gamma knife is sometimes not available. So we must not make gamma knife an option for the fact that we haven't dissected enough, or somebody in the West who has access to all this says that gamma knife is a better option. Please don't do that. So go ahead, use high magnifications and operate. Okay. Of course, there will be some, whenever you start a fire, there will be smoke. So you will have some struggle. And once the fire really starts up, then all the smoke, everything will be gone and your world will be lit up, isn't it? So that's how surgery is. You must know the limits of surgery, but you must also know what surgery can get you. So this is the overview there, the third, fourth, V1, V2, up to V3, all the clinoidal triangle, everything taken out. And I think that would be the end of it. Thank you very much. God bless. Thank you, Ahmed, for giving me this chance. Any questions, I'd be happy to answer.
Thank you, Dr. Aibed, Dr. Ahmed, for for this nice, good, excellent presentation with the difficult operations videos. And we can start now, Dr. Ahmed, for discussion. If any question for Dr. Aibed or Dr. Mujahid.
Thank you, Dr. Mahjabin.
Our colleagues.
Thank you, Dr. Mahjabin, and thank you, Dr. Aib. Unfortunately, Dr. Victor Hugo Perez should have a presentation today as well, but he sent me a text that he is now at a conference at Mexico City, and he is not able to join us. So we'll postpone his lecture to another time. So now we'll see if there is any questions or a discussion in the chat. If anyone have any question, please let us know in the chat or ask directly. All I see here is compliments about the nice presentations. So
No
I
questions.
guess there is. Dr. Mujahid, do you have any question, Dr. Mujahid, or do you have any comment?
No, it's good, nice. But we are unlucky for this Dr. Victor. Excuse. I think there is no questions, yeah?
Yes, there is no any question in the chat, and I don't see anyone want to ask any question for now. So I think by this we can conclude our session. And thank you, Dr. Mahjabin, and thank you very much, Dr. Aib. Thank you for these excellent presentations and nice sections. And so, Dr. Mujahid, you can conclude the session.
Thank you, Dr. Ahmed, for this. Thank you again, Dr. Ahmed, for this nice preparations and continuous program of this lectures by our society, Yemen Society of Neurosurgery. And thank you for all joining our lectures and our program. Thanks to Dr. Ivan next time, and Dr. Mahjabin Mimon. Thanks all. See you, inshallah, soon.
Thank you so much.
Next
Thank
week.
you,
Thank you, everybody. See you then.
See you again soon.